So even though acute coronary syndrome kind of dominates our idea of what a cardiovascular emergency is, it's not the only type of cardiovascular emergency. There are many other types of cardiovascular emergencies, including cardiac tamponade, cardiogenic shock, um, hypertensive crisis, and so on and so forth. And we're going to talk about some of those in this lecture. So let's first talk about cardiac tamponade. Cardiac tamponade. And cardiac tamponade occurs when the buildup of pericardial fluid compresses the heart, impairing contraction and restricting ventricular filling. You may develop gradually, if it's caused by an infection, like pericarditis or a tumor, or rapidly if it's caused by heart surgery, pacemaker or central venous catheter insertion, or cardiac trauma such as a stab wound or gunshot wound, which is probably the most classic understanding of the cause of cardiac tamponade would be the traumatic cause. Just real quickly, so if this is your heart, excuse my drawing, all right, you have the sac around the heart, and there's normally pericardial fluid in there, like a small amount, to reduce the amount of friction that occurs because there's movement. Whenever there's movement in the body, there's going to be friction. So your joints have a fluid around your joints, right, within that bursa, and your spine has spinal fluid. Everywhere in your body, there's fluid if there's movement. Your lungs have fluid around them, or in the pleural sac. And in the pericardial sac, you have fluid because of the friction that can be caused due to contraction and relaxation. When that fluid builds up and pushes this way, down on the heart isn't going to be able to fill as well or work as well. So you might see one of the classic findings is JVD due to that backup because the heart's not able to fill, and the jugular veins is one of the places that will engorge from not being able to empty its contents into the right side of the heart. So when it comes to assessing these patients, it's usually pretty difficult to get their medical history because they're going to be pretty ill. So you're going to want to base a lot of your assessment off signs and symptoms in the presentation. So the symptoms that they might have would be something like anxiety, restlessness, maybe some shortness of breath, definitely some chest tightness or some dizziness. You're also going to want to suspect cardiac tamponade in any patient that has had a penetrating wound of the chest or upper abdomen. And if it's not from trauma, the patient may have a history of a medical illness such as pericarditis or an end-stage renal disease. You want to be able to differentiate between a tamponade and a tension pneumothorax. Specifically in cardiac tamponade, the lungs are not affected, so breath sounds will be equal and the trachea will be midline. Cardiac tamponade actually produces a classic trio or triad, if you will. It's known as Beck's triad, and it is JVD, hypotension, muffled heart sounds. Now, muffled heart sounds aren't that common. They present in fewer than half of all of the patients that have had cardiac tamponade. But Beck's triad is JVD, hypotension, muffled heart sounds. And you can kind of get an idea of why you get those things. We explain JVD because of the backup of blood flow, and hypotension because if you back up blood flow, you're not able to fill the heart as well, of course. And so cardiac output is going to be low, so the blood pressure is going to go down. And then muffled heart sounds simply because there's fluid around the heart, a buildup of fluid, so there's a barrier when it comes to auscultating the heart sounds. Some other signs of cardiac tamponade include signs of shock, like your cold, pale, mottled, or cyanotic skin and your tachycardia. It is a form of obstructive shock, keep that in mind. So you're going to see those signs of shock. Weak or absent peripheral pulses. Narrowing pulse pressure is an early sign. So you'll get that narrowing pulse pressure and then you'll get hypotension. Pulsus paradoxus, which is a late sign, and it may be absent if the patient has severe hypotension. Remember, pulsus paradoxus is changing in the pulse with respiration. And then signs and symptoms mimicking heart failure. All right, and then an EKG is a limited value, but it may show electrical alternans And electrical alternans, it's that small QRS, large QRS, small QRS, large QRS. Just pretend that's a QRS, even though it was flat on top. All right, so little big, little big, little big. That's an electrical alternand. So this would be more like this. That was my mistake. Get your electrical alternans. Let's fix that. And that's a symptom or sign, excuse me, on an EKG indicating cardiac tamponade. It's, like I said, of limited value. So you might be wondering, what can you do for these patients with cardiac tamponade? And a pericardiocentesis is the indicated treatment. Not a lot of agencies will perform a pericardiocentesis. However, if they do, that is the prescribed therapy for a patient with pericardial tamponade. If trauma is the source of the patient's signs and symptoms, you're going to want to address any life-threatening hemorrhage, ensure adequate oxygenation and ventilation, apply that pulse ox, and provide oxygen as needed to maintain an SaO2 of 94% or higher. And then you're going to want them on an EKG and avoid performing additional procedures that might delay transport. Establish IV access en route to definitive care. Your pericardiocentesis is the ultimate treatment to withdraw the fluid. And the way you do it is a needle is inserted into the pericardial space to aspirate the excess fluid. Withdraw as little as 50 mLs, and it may give a significant amount of improvement to the patient. Transport to a facility that can do this procedure if it's not done pre-hospitally, especially. And the way it's done is you take a large cardiac needle or spinal needle, attach it to a very large syringe, like a 60 cc syringe, and you're going to enter just substernally below the xiphoid process on the patient's left side, aim the needle towards the midclavicular line and enter at a 45-degree angle. And as you're entering, you're going to have them on the monitor, watch the rhythm, and aspirate the entire time. You're going to hold negative pressure on that syringe the entire time until you start getting blood flow, or until you see an adverse rhythm on the monitor, or a rhythm change on the monitor, and then you'd back out because you may have gone too deep. Next, we'll talk about cardiogenic shock. Cardiogenic shock may occur as a complication of shock of any cause. And it may also occur if myocardial contractility has diminished because of prolonged cardiac surgery, ventricular aneurysm, cardiac arrest, or ventricular wall rupture, which occurs post-MI a lot of the time. And a transient cardiogenic shock can occur after resuscitation. So after the patient's resuscitated, you can have a transient cardiogenic shock. So let's talk about assessment of the patient with cardiogenic shock. If family members are present, ask whether the patient has a history of heart disease. It's a big one. Obviously, heart disease is very common, so there's a good chance. History often includes cardiomyopathy, congenital heart diseases. You want to find out about any of those. A recent myocardial infarction, especially in patients who are older adults, have had STEMI, have had a history of a previous MI or heart failure, have an anterior infarction at the same time shock develops. You're going to want to assess for all of those things. Compensated cardiogenic shock is when the patient may experience the following symptoms: restlessness, agitation, confusion, crackles in the breath sounds. When you have hypotension in addition to pulmonary edema, you should assume cardiogenic shock is present. So those crackles with breath sounds and hypotension is a big indication. You might have JVD or a weak and rapid peripheral pulse. The patients may experience pale or mottled skin, cool, moist extremities, any of your normal signs of shock. And a narrowing pulse pressure is another thing you might see with cardiogenic shock. The EKG may show evidence of both an old or a new infarction, right? And a right-sided chest lead can detect a right ventricular infarction. So if they have an inferior wall MI, check the right side, because right ventricular infarction causes hypotension in a lot of patients, which can cause cardiogenic shock. If associated with cardiac tamponade, your muffled heart sounds might be heard, just like we talked about with Beck's triad. And decompensated cardiogenic shock, the symptoms are even worse. The patient may be altered, have rapid and shallow respirations. Pulmonary congestion might be even worse. Absent peripheral pulses, weak and rapid central pulses. The skin would certainly be pale, mottled, or cyanotic. cold and sweaty extremities. In those patients, you're going to want to move a lot quicker to get them perfusing better. As ventricular function worsens and cardiac output fails, the systolic blood pressure will progressively decrease. So obviously, it's going to be becoming lower and lower as perfusion worsens. So the management of cardiogenic shock focuses on strengthening contractility without increasing the heart rate, altering preload and afterload, and controlling any dysrhythmias that are contributing to shock. Okay, so you want to strengthen contractility, but you don't want to increase the heart rate in your tachycardic patients, and you want to control any dysrhythmias that are contributing to the signs and symptoms of shock. Apply a pulse oximeter and administer supplemental oxygen as indicated, of course, maintaining a SpO2 greater than 94%, like always. And place the patient in a sitting position with the feet dangling, especially if they have pulmonary congestion, right? If they're super hypotense, you don't necessarily want to sit them up because they're going to, supinate themselves. They're going to go unresponsive on you. So if they're hypotense, you might want to keep them in like a semi-Fowler's to almost supine position. But remember, pulmonary congestion can complicate that positioning and cause them to go into respiratory failure. So you may want to have to kind of balance between the two, between supination and full sitting upright, and have a semi-Fowler's position. Make sure you ensure that you limit the patient's physical activity while they're in your care. Just like a myocardial infarction patient, this may in fact be an MI patient. Place the patient on cardiac monitor and establish IV access as needed, and obtain a 12-lead EKG and maintain normal body temperature. Any patient in shock, you want to try to maintain normal body temperature. Give IV fluids and medications per your local guidelines or per medical direction. Administer a trial of fluids to determine whether the shock has a hypovolemic component. A lot of patients, especially the elderly, become hypovolemic secondary to dehydration anyhow. So definitely consider a fluid challenge. Even if you hear some crackles, just because you hear fluid in the lungs doesn't mean giving them more fluids is going to make the fluids in the lungs worse. And I know that's a hard thing to understand, and it's difficult to explain, but they're third spacing their fluids. So if the fluid is in their lungs, one place that it isn't is in their vessels. So they may actually be vascularly dehydrated even if they have pulmonary congestion. But if you do give fluids, rapidly infuse 100 to 200 milliliters normal saline and closely monitor the patient's mental state, their breath sounds, their pulses, and their blood pressure. Withhold further fluid administration if the patient's condition deteriorates or the crackles get worse. Hepatomegaly might develop as well. So your vasoactive IV medications that you might use to treat cardiogenic shock, which are going to be your pressors, are dopamine, norepinephrine, which is also known as Levophed, and epinephrine we know is adrenaline. Your norepinephrine, epinephrine are definitely going to help with the sympathetic nervous system. Dopamine is good with the inotropy component. It helps with that force of contraction and contractility. If you're instructed to give the vasopressors, you're going to want to check the following. Make sure you're constantly assessing that IV site. You don't want any infiltration. And assess for the patient's response anytime you do a treatment. But of course, if you're providing vasopressors, you're going to want to make sure you're getting your vital signs very often. Give additional emergency care as instructed by medical direction if the patient does not improve, and treat any dysrhythmias that are contributing to the shock. Of course, ventricular tachycardia comes to mind. If some of these in VTAC, there's a good chance they'll be in cardiogenic shock as well. If you treat the VTAC, you might actually cure the cardiogenic shock. So, of course, you're going to treat the dysrhythmias contributing to the shock. Provide emotional support to the patient and the family, as always, and except for correcting a life-threatening dysrhythmia, there are no other measures you can take in the field to stabilize a patient in cardiogenic shock. So get moving towards the hospital. And if your system indicates, complete a fibrinolytic checklist en route to the hospital. Next, we'll talk about a very common type of call, your hypertensive emergency. And your hypertensive emergencies are defined as a diastolic blood pressure exceeding 90 millimeters of mercury. a diastolic pressure exceeding 90 millimeters of mercury, not systolic, which is what most people think of when they're trying to diagnose hypertension. It's called the silent killer because it usually produces no signs or symptoms, and a person can have it for years without even knowing. And we know uncontrolled high blood pressure can cause things like a stroke, a heart attack, heart failure, kidney failure. It could even cause low vision or blindness, and the increased risk for these lethal illnesses, really. And a hypertensive emergency is defined as an acute elevation of blood pressure with evidence of end organ damage, and it's a common cause of the failure to take blood pressure medications is a common cause, or other treatments as prescribed. And another cause is a result of toxemia of pregnancy. We know that as preeclampsia, right? And preeclampsia can lead to eclampsia, which is seizures during pregnancy. And there's very few times that we treat hypertension pre-hospitally, but one of those times might be an eclamptic pregnant patient. Hypertensive encephalopathy, also known as acute hypertensive crisis, may complicate any form of hypertension. Usually it's signaled by a sudden escalation of blood pressure to levels exceeding 200 over 130. So hypertensive encephalopathy, 200 over 130. It's very, very bad, very high blood pressure. Most cases of hypertension result from advanced atherosclerosis or arteriosclerosis, and the blood pressure at rest might be something like 140 over 90. That's kind of the go-to in diagnosing hypertension, is that 140 over 90 blood pressure. A single reading does not constitute hypertension, though, right? You're going to want to tell the patient to have their blood pressure rechecked over several months, and even when they're in your presence, you're going to want to check their blood pressure several times before you actually diagnose them, with acute hypertension. Persistent elevation of a diastolic pressure is indicative of a hypertensive disease, which can significantly shorten a lifespan. And again, it leads to those renal damage patients and stroke and heart failure. Hypertensive emergencies require rapid lowering of pressure to prevent or limit organ damage. And a lot of times that happens in the hospital. But your malignant hypertension patient, when their MAP, or mean arterial pressure, exceeds 150 millimeters of mercury, fluid can leak through the blood-brain barrier and cause an increased ICP, intracranial pressure. So that's a very, very bad patient. Your malignant hypertension patient occurs when there's a rapid rise in blood pressure. It causes an acute and progressive damage to organs such as the heart, brain, and the kidneys. So you're definitely going to want to treat that patient or get them to the hospital pretty rapidly. Their first noticeable symptoms might be something like a severe headache, nausea, or vomiting. They kind of present like that patient having a migraine. But then it could be followed shortly thereafter by seizures, an altered mental state, or they might even have like sudden blindness, aphasia, or hemiparesis. And if they're untreated, they might even die within a few hours. So the malignant hypertension patient is pretty bad. There's also something called autonomic dysreflexia, which is a sudden rise in blood pressure following a newer onset paralysis. So a patient that becomes paralyzed, within that first year, they're at high risk for this autonomic dysreflexia. And that might even be a patient that you'd want to get orders to treat as well, because that's going to be a type of malignant hypertension. So let's talk about assessment of the hypertensive emergency. They often develop rapidly with hypertension, and the symptoms can include headache, blurred vision, dizziness, tinnitus, right, ringing in the ears, dyspnea, or shortness of breath, chest pain or tightness in the chest, nosebleed or epistaxis, muscle cramps, weakness, palpitations, paroxysmal nocturnal dyspnea or orthopnea can occur with hypertension. So you want to ask the patient about what medications he or she might take, if they're prescribed or if they're over-the-counter medications. Recreational drug use might also be something you want to ask about. Signs or your objective findings for these patients could be their skin appearance that might be flushed, right? Mental status that may range from responsive to altered or unresponsive. Those malignant hypertensive patients could be altered. Your stroke patients, altered, so on and so forth. Pale, flushed, or normal skin that feels dry, moist, or warm or cool. Strong, bounding peripheral pulses, high diastolic blood pressures, again, diastolic blood pressures, usually higher than 130 for your severe hypertensive crisis. Seizures, of course, would be bad, and signs of heart failure. Signs that are consistent with an acute myocardial infarction, so you're going to want to make sure you do a 12 EKG and look for any ischemic changes. Of course, we start management pre-hospitally for the hypertensive emergency. You might need to administer oxygen, maintaining oxygen saturations greater than 94%. Establish an IV line. Put them on the EKG. Again, get the 12 lead. Get a pulse ox. Do not delay transport. Provide care according to the local protocol for patients with heart failure or chest discomfort. Again, hypertension could be secondary to something else, so treat what you can treat or what's indicated to be treated. And offer reassurance to the patient and to the family. As always, that's commonly forgotten, but by doing that as a provider, you're going to put them at ease and maybe even bring down their blood pressure somewhat. If a long transport time is unavoidable, paramedics may need to initiate drug therapy in the field. So labetalol is a common treatment. Alpha and beta blocking properties decrease overall peripheral vascular resistance and prevent reflex tachycardia. All right, contraindicated in patients with asthma and COPD, labetalol. Keep the patient supine, measure the blood pressure at least every 2 to 3 minutes, especially if you're treating the patient, and stop the infusion when the blood pressure has fallen to the target level. All right, so constantly monitor these patients that you're treating for hypertension and stop any treatment once they've reached their target level. Next, we're going to talk about some infectious diseases of the heart. All right, so endocarditis, that's the first one, and it kind of makes sense that endocarditis is an infection of the inner lining of the heart, which is known as the endocardium. And endocarditis literally means inflammation of the endocardium. All right, so the inner lining of the heart. And it occurs when bacteria in the bloodstream colonize a heart valve or other damaged tissue in the heart, and they begin to multiply within that endocardium. Patients at risk for endocarditis include those with mitral or aortic valve disease, prosthetic heart valves, congenital heart disease. Your right-sided endocarditis, affects the tricuspid and the pulmonary valves. Your IV drug users are also at risk for this, and patients with infected central venous catheters, dialysis shunts, or transvenous pacing wires. So things that go into the body from the outside, bringing in that bacteria, can cause, especially your right-sided endocarditis. The virulence of endocarditis is reflected by the severity of the patient's illness. So if it's mild, they're going to have gradual symptoms, low-grade fever. If it's severe, it's a serious illness over days to weeks with a high-grade fever. That severe endocarditis obviously is not desirable. Assessment, you're going to want to look for symptoms like fever, chills, headache, loss of appetite, weight loss, muscle, joint aches and pains, night sweats, some dyspnea, maybe cough, heart failure, Janeway lesions, Osler nodes, also indicative of endocarditis specifically. EKG changes may be seen, including a prolonged PR interval, a third-degree AV block, or a left bundle branch block. Anytime you have inflammation of heart layer, you could have EKG changes. You want to manage these patients supportively, allow a patient to assume a position of comfort, establish IV access, of course, and apply the cardiac monitor, and put them on pulse ox, administer oxygen if needed to maintain an O2 saturation greater than 94%. And if the patient has heart failure, follow local protocol and medical direction. Again, there could be other things going on with this patient, so treat those things as indicated. And the definitive treatment is going to be, your antibiotics. They may get surgery in severe cases. And if it's left untreated, they could have valvular prolapse and regurgitation. Another type of infectious heart disease is pericarditis. All right, pericarditis is an inflammation of the pericardium. It's caused by either a viral, which is the most common, bacterial, or occasionally a fungal infection. And in many cases, no cause can be identified. It's what we call idiopathic pericarditis. With your assessment of this patient, again, pericarditis is going to be inflammation of that pericardial sac. The sac around the heart can cause pericarditis. And with your assessment, you're going to ask the patient about recent flu-like symptoms. And the patients may relate a history of a recent upper respiratory infection. That's very common. The chest discomfort is the most common symptom of pericarditis, and it could be sharp, stabbing chest pain that is made worse by deep inspiration, coughing, or lying flat. Remember, it's sharp, stabbing chest pain made worse by deep inspiration, coughing, or lying flat. That's really pathognomic of a pericarditis. And the pain decreases when sitting up and forward. So a lot of times if the patient leans forward, the pain from acute pericarditis will go away. Listening to heart sounds may reveal pericardial friction rub. It's not always present. It's very uncommon. Other signs might include pale skin, JVD, normal breath sounds, unless another condition exists. An ST segment elevation and multiple EKG leads. In fact, the kind of classic acute pericarditis finding on a 12-lead EKG is global ST elevation, almost every EKG lead, which looks like early repolarization. And management pre-hospitally is going to be supportive. It's going to be your IV O2 monitor management and O2 as needed, again, to maintain SpO2 greater than 94%. Pericarditis is treated eventually with non-steroidal anti-inflammatory drugs. So your NSAIDs, your viral pericarditis usually resolves on its own. Bacterial can be treated with antibiotics, and of course fungal pericarditis can be treated with your antifungal medications. Next, we have another infectious disease of the heart. So we talked about the endocardium and we talked about the pericardium. So let's talk about the myocardium with myocarditis, inflammation of the myocardium. It's usually benign and self-limiting, which is good. If untreated, it will impair the heart's ability to pump and may result in a right ventricular failure or a left ventricular failure, dysrhythmias, could cause death or dilated cardiomyopathy. It can be caused by bacteria, viruses, parasites, rheumatic fever, exposure to chemicals or poisons, even alcoholism or radiation therapy, or could be idiopathic. In the assessment, you're going to want to look for things like fatigue, decreased appetite, mild dyspnea. They might have aches and pains in their joints, and they could be febrile. With all your itises, with all your inflammation patients, they could certainly be febrile. They might have palpitations or chest discomfort that's often sharp, stabbing in the center of their chest. And tachycardia, tachypnea, atrioventricular dysrhythmias are common. Your right or your left bundle branch blocks, and then they could have pulmonary congestion or even systemic congestion, like with ascites and peripheral edema. The ECG may show low voltage QRS complexes in all the leads. And the differential diagnosis to consider for myocarditis include the following: acute coronary syndrome, aortic dissection, esophageal perforation, rupture or tear, heart failure, Kawasaki's disease, pneumonia, or pulmonary disease. So you want to have a good differential for those patients that present similarly and try to narrow in on what you think is going on with that patient. Management for pre-hospital patients with acute myocarditis isn't really a whole lot more than being supportive like these other patients. You're going to allow the patient to assume the position of comfort, do your IV O2 monitor as needed, and of course get 12-lead EKGs and vital signs regularly. Next, we have rheumatic fever. Rheumatic fever is an inflammatory disease caused by streptococcal bacteria, so strep, right? It causes mitral valve stenosis, leading to heart complications. And again, the management for this patient pre-hospitally is going to be mostly supportive, IV O2 monitor. Next, we have scarlet fever. Scarlet fever is caused, again, by strep, so streptococcus, but this is pyogenes bacterium. And the signs and symptoms include a sore throat, fever, rash, and a strawberry tongue. That's kind of in quotes, strawberry tongue. You have to Google a picture of that to see what it looks like. Patients younger than 1 year are at the greatest risk of scarlet fever, and treatment includes antibiotics with supportive pre-hospital care. Again, your IV O2 monitor. Next, we're going to talk about some vascular disorders, and the first one we're going to talk about is the aortic aneurysm. Aortic aneurysm is one that is the dilation or outpouching of a blood vessel or the wall of a chamber of the heart. Of greatest concern are those that involve the aorta, such as an acute dissecting aneurysm of the aorta. And again, the aorta comes off of the heart, so you have the ascending aortic arch. And this lining, it could develop a bulge or an outpouching, right, where blood starts to build up in there. And if the pressure builds up enough, this can rupture, and blood that's flowing could then leak out, and you could have a pretty severe hemorrhage and even death. So, aortic aneurysm may be benign with a tear in the inner lining of the aorta, which is the intima, right, tunica intima, near the weakened portion of the vessel. Blood flows through the tear and between the layers of the vessel wall, exposing the middle layer to blood under high pressure. So that tunica media is going to now be exposed. And then blood fills the space between the layers of the vessel, causing them to separate or dissect. With each ventricular systole, blood is forced into the torn arterial wall, which creates a false channel between the intimal and the medial layers of that aortic wall. If the dissection goes back all the way to the aortic valve, it could actually hinder it from closing, which will allow blood to regurgitate back into the left ventricle during systole, which is, not supposed to happen. So you'd have poor cardiac output in that case. And then you could also have, because of that dissection all the way down to the aortic valve, you could have coronary blood flow that becomes compromised as well, making it look like a acute myocardial infarction on a 12 EKG. If the dissection involves the takeoff point of the innominate left common carotid or the left subclavian artery, blood flow through those affected arteries will obviously be diminished. Most of these dissecting aortas will begin in the ascending aorta, just about 2 inches from the aortic valve, or in the descending thoracic aorta at the site of the ligamentum arteriosum. Arteries will lose elasticity prematurely through different pathologies, including atherosclerosis, which is the most common, hyperlipidemia or high cholesterol, hypertension, coronary heart disease, and medial degeneration. Aneurysms of the ascending thoracic aorta are usually caused by cystic medial degeneration, a connective tissue disease in which normal elastic tissue is replaced with cyst-like connective tissue. A mild form is often present in the aorta of older adults. It may be a natural consequence of aging. In younger people, it is accompanied by Marfan syndrome. Marfan syndrome, it's those tall, lanky, kids. Usually they have like longer fingers or whatever, and it's a connective tissue disease that can, unfortunately, it's often diagnosed post-mortem because they end up having aortic dissections. But you could also have congenital problems, or other congenital problems. Trauma, syphilis can cause this, ineffective endocarditis, and the other infections, of course, can cause connective tissue disorders. When assessing the patient with acute dissecting aneurysm of the aorta, you're going to look at signs and symptoms as they depend on the location. The pressure of a large amount of blood on the surrounding organ may produce symptoms, so the location of the dissection is going to cause different symptoms. The patient's description of the pain provides clues to the location of the dissection. Almost all patients report the abrupt onset of constant, unbearable pain. Ascending aorta dissection is usually associated with pain that is either substernal or located in the neck, throat, jaw, or face, so more superior, where your descending aortic dissection usually produces flank pain or pain between the shoulder blades, pain in the back, abdomen, or lower extremities. Your classic pathognomic presentation is that tearing or that ripping pain in your back. course, it may be difficult to distinguish the chest pain of a dissecting aneurysm from that of an acute myocardial infarction, but a number of distinctive features may help to differentiate the two. So here you have a table. Obviously, the onset of the pain is a big help. Gradual, pain is more indicative of acute myocardial infarction. Your abrupt, without prodromal symptoms, is more indicative of your aortic aneurysm. The severity of the pain, where your MI increases with time, the aortic aneurysm is maximal from the outset. It's a really bad pain right from the beginning. The timing of the pain, an acute myocardial infarction pain may wax and wane, where aortic aneurysm does not abate once it has started. It's just constant and it's maximum pain. Location of the pain, acute myocardial infarction pain, is typically, remember, you could have an atypical MI, but typically it's substernal. The back is rarely involved, whereas with an aortic aneurysm, the back is often involved. That's one of the main places a lot of people complain is between the shoulder blades. Clinical signs, your peripheral pulses are typically equal in all other patients, but with an acute myocardial infarction. But with a aortic aneurysm, your blood pressure discrepancy between the arms or decrease in the femoral carotid pulse due to the location of that aortic aneurysm. So the patient with an acute dissecting aneurysm of the aorta would have some symptoms, including anxiousness or the feeling of impending doom, which is always a bad one, right? Pain, weakness. A common symptom is numbness and tingling, what we call paresthesia, in the extremities. It may be so bad that they'll want to, jump off the stretcher. Signs of myocardial ischemia, heart failure, altered mental status, stroke, paraplegia, cardiac arrest, sudden death, of course, and syncope are all symptoms of an acute dissecting aneurysm of the aorta. So ascending aortic dissections occur in younger patients that are previously in good health, and one or more of the vessels of the aortic arch is compromised with these, and the pressure may be different between arms. So you may have a pressure that's 20 millimeters of mercury or greater in difference between the left arm and the right arm, and that's an indication of an aortic aneurysm. You want to suspect dissection if the patient is accompanied by acute neurologic changes, and they could show signs and symptoms of a stroke. And there are EKG changes, which are typically characteristic of myocardial ischemia that you might see on an aortic dissection when that dissection extends proximal to the coronary artery ostia, which are the openings of the coronary arteries. So when you get a dissection that gets close to that, then you might get blood loss before those coronary arteries are perfused. So, of course, changes that show myocardial ischemia, myocardial infarction might show up on a 12-lead EKG because there's no blood flow to that area. So your descending aortic dissections are more common in your older patients, especially in those with a history of hypertension. The pain is less severe than your ascending aortic dissections, and distal pulses may be hard to feel, of course, because they're not getting that distal blood flow as well. The rupture of the thoracic aneurysm could occur, and with a rupture of a thoracic aneurysm, you could actually have signs and symptoms of a hemothorax if it ruptures into the pleural cavity, or you could have signs of a cardiac tamponade if a thoracic aneurysm ruptures into the pericardial cavity. Then going down the descending aorta, if you have a ruptured abdominal aortic aneurysm, that's called a AAA, right? That's when you get that classic sudden onset of tearing back pain that's accompanied by abdominal pain and pretty severe tenderness as well. The patient might be hypotensive and have a pulsating abdominal mass. That's another classic finding, is the pulsating abdominal mass between the xiphoid process and the umbilicus. And then they're going to be sensitive to palpation and quite tender, as I said, and abdominal distension, of course, from the blood buildup within the abdomen could occur. And then the last thing we're going to talk about is the management of these patients with aortic dissecting aneurysms. The goal of the pre-hospital management is to provide adequate pain relief and rapid transport. They need to get surgery. Okay, so establish an IV line, apply the cardiac monitor, apply pulse ox, administer oxygen if indicated, as always, to keep the O2 sats above 94%. Give IV fluids, medications per local guidelines. You may want to allow for relative hypotension. You don't want to dilute their blood too much. So allowing for some hypotension is okay to allow for the clotting process to also kick in. Administer opioids if the patient's blood pressure can tolerate it, and do not delay transport. Nothing could be done to stabilize the patient's condition in the field beyond, giving them fluids and monitoring them. There's nothing you can really do. The patient requires aggressive therapy in the intensive care unit and probably surgery. So that will bring us to the end of this video on cardiovascular emergencies.